Hello everybody, and welcome to the Thursday edition of Video Clips. And I found an interesting article in JAMA Cardiology that I thought was worth discussing. And I added some information to it because it really, there are a couple of different perspectives that I think we should consider. So the title of the article is Fear of Coronavirus 2019, or Coronavirus Disease 2019, an Emerging Cardiac Risk. And what the authors of this are basically saying is that the fear of the virus is keeping people from getting the right kind of care, which is then causing collateral damage, which I talk about all the time in these videos, right? So here's what these authors have to say, and I'll be clear about where I'm inserting something that's my information, not part of this article. We're in the midst of the coronavirus disease 2019 or COVID-19 pandemic, and as many clinicians across the globe are seeing firsthand the pain and death caused by COVID-19. While there are more than 300 clinical trials currently underway for this illness, they talk about we're nowhere near to overcoming it. And I don't necessarily disagree with that, but the most important point about this, and I wanted to be clear about their total perspective here, they say in response to dire predictions and a lack of effective treatments, authorities across the world continue to recommend a series of aggressive mitigation strategies to slow the spread of COVID-19. While early fears of widespread death and overwhelmed hospitals have played an important role in sounding the alarm, these fears have caused substantial harm. And I'll add, they really didn't turn out to be true either, which was a good thing. We should be celebrating that. Instead, we should be celebrating the fact that it wasn't as bad as we thought it was going to be, and instead, this other thing is going on. So they use cardiac disease as an example and explore the hazards associated both with the pandemic and initial response and how it affects cardiovascular disease. So here's what they basically say. As the global death toll from COVID infections continues, nearly all patients with infections will recover. The discrepancy between population and individual risk results from three complementary observations. First, it appears that the mean infection fatality rates are low, likely less than 1%. Second, mortality risk from COVID-19 is heterogeneous across age groups and comorbid conditions. And third, as is common with population risk distributions, most patients have risks that are less than the mean. Our concern, the authors say, is, and they're saying the same thing that David Katz said that I told you about on Tuesday. We're doing this broad swath of response that doesn't necessarily, it's not appropriate for all groups. Our concern is that the mitigation strategies that seek to reduce the very real risk of spreading the virus across the population may lead people to delay or forego essential care because of a tendency to overestimate their individual risk with given exposure. So what they talk about next is that one of the most important things from a cardiovascular standpoint is for patients to have checkups and procedures and that sort of thing. And they're talking about the fact that there has been a significant risk, 40% drop in the use of the catheterization laboratory, which means that a lot of patients are at higher risk of cardiovascular disease, or so they say. All right, so far what I've said to you is that this group feels the same way as Dr. Katz, where the mitigation strategy is too heavy-handed and it's not targeted. The second thing they say is one of the negative effects of this is people aren't going to the cath lab, and they're not getting stents, right? But let me tell you some good news. The best thing that could happen for people is not going to the cath lab. So just to tell you, stents are small wire implants that are used to open blocked arteries. They can save lives for patients who arrive at the hospital during or shortly after a heart attack. The problem is that most stenting procedures involve people who have no pain and discover that they have a blocked artery due to imaging. In other words, the visits that they're telling you people should be doing right now, they find out by accident. People who have chest pain, that occurs during exertion. Almost 2 million stents are implanted every year at a cost of between $11,298 and $36,221, okay? For a long time, it's been suspected that stents were being overused, causing harm to patients and burdening the healthcare system with billions of dollars per year in unneeded expense. Research dating back to 2007 shows that stents did not reduce the risk of death, non-fatal myocardial infarction, or hospitalization for acute coronary events. Research also shows that stenting does not produce better outcomes than less invasive approaches, such as just taking drugs. The AVERT study, which involved randomizing patients to take Lipitor or have angioplasty, showed that patients who just took the Lipitor had fewer heart attacks, less chest pain, and made fewer visits to the hospital than those who had the angioplasty. Some studies have even compared stents to placebo and showed that there was no difference. One study that included 200 patients involved using a catheter to reach the blocked artery, but only half the patients were given the stent while the controls were not. 6 weeks later, no difference between the two groups. Patients in both groups said they had less chest pain, and both groups did much better on treadmill tests. A meta-analysis published in 2012 also showed that stents were useless for most patients. 3 of the studies included people who already had a heart attack, and 5 studies looked at people who had stable coronary artery disease but had experienced no previous events. The analysis showed that patients who received stents along with drugs were no better off than patients who were just prescribed drugs. This is particularly stunning in view of the fact that the drugs are fairly useless. For example, one study showed that taking Lipitor reduced the risk of a heart attack by only 1.1%. Another showed that taking Lipitor extended lifespan by an average of only 3 to 4 days. In addition to the uselessness of the procedure, in most cases, not all, but most, angioplasty and stenting can cause harm. Often the inflating of the balloon nicks a plaque and causes the toxic ingredients to be released, which then activates clotting mechanisms. The result is between 15 and 20,000 heart attacks and 10,000 deaths per year during the procedure. So this is the first part of the article where the doctors in the JAMA article are saying there's been a 40% drop in the use of the cath lab. What I'm saying, this is my information, is that that is probably a good thing because we do way too many stents and they don't improve outcomes, and in some cases worsen outcomes because we're doing too many stents on the wrong people. So I don't often come on this channel and tell you that good things are happening as a result of COVID, but from the standpoint of people avoiding care that is useless and excessive, that would be a good thing, right? Now, there's another thing, though, that is a risk factor. I'm going to return to the doctors because they make a very valid point. And they talk about risk association with disasters. Disasters increase the population risk of cardiac events. Widespread fear and emotional stress are known to directly precipitate acute coronary syndromes through abnormalities of autonomic tone that can increase platelet aggregation and rates of plaque rupture. Psychological distress seen during some disasters also increases event rate through indirect outcomes such as increased rates of smoking and sedentary lifestyles. And they cite Hurricane Katrina as an example. Previously considered the costliest natural disaster in U.S. history, they say it offers very important lessons. Prior to Hurricane Katrina, the rate of hospitalization for myocardial infarction at Tulane Health Sciences Center in New Orleans was 0.35% of all admissions per year. This rate increased over the following year to 1.09%, a threefold increase over the pre-Katrina baseline. Evidence of increased risk of myocardial infarction in New Orleans persisted for years after the catastrophe, a pattern that has been seen in many other natural disasters. If the COVID-19 pandemic presents a similar hazard to the entire nation, it's likely we'll see 1 million to 2 million additional coronary events that are directly attributable to the current crisis. This increase, coupled with worse clinical outcomes when patients avoid seeking effective care, creates a double hit. And then they go on to talk about you have the actual community fear that can increase the risk of heart attacks, and then you have the fear that people have about going to the hospital. And they go on to talk about the fact that, before people thought hospitals were safe places to be, and now they find that there's sometimes unsafe and unpleasant places to be. I mean, I've reported some episodes in hospitals where you just wonder, how can they treat people this way? Well, it's just life in COVID land, right? But the authors talk about the fact that the hospital needs to go back to being a place where a person who thinks he or she is having a heart attack feels like they want to go. And there was an article to that point in a local newspaper here in Columbus, where a cancer patient was having some kind of breathing difficulty or whatever, and his mother wanted to take him to the hospital, and he begged her not to do it. He said, being in that place without any family, I just don't know if I can take it. And of course, previously what a patient would say is, yes, something is clearly wrong and I need help, so please take me to the hospital. So all in all, we've got good news and we've got bad news. And the good news is that the use of a lot of useless medicine is down. People have stopped hanging around with doctors for no reason. The use of procedures that are questionable, marginal is going down. The bad news in all of this is that the fear out there is making people sick in a different kind of way. And it's also causing people who actually do belong in a hospital to not want to go there. And so, and they basically started their article in the same way that David Katz starts many of his, by saying, look, we have to go about this with much more surgical precision. I think, David has talked about it that way, where we're just much more precise in the way that we go about doing these things, instead of this big swath of regulations that one size fits all. Here's an update on the upcoming COVID vaccine that I think you want to know about, which is the American Academy of Pediatrics is asking the government to include children in the vaccine trials. On September 29, 2020, Zaragoza, medical director and president of AAP, wrote a letter addressed to Health and Human Services Secretary Alex Azar and Food and Drug Administration Commissioner Stephen Hahn, stating children must be included in vaccine trials to best understand any potential unique immune responses and/or unique safety concerns. Currently, none of the current COVID vaccines in clinical development are being tested in children under the age of 18 years. Now, I don't know what you think about that, but her point is not completely out to lunch, because, for example, in Massachusetts, the governor has said that everybody from age 6 months to all children age 6 months to college age must have a COVID vaccine. So essentially what this person, like the governor, is doing there is, at least as it stands right now, he's saying we're going to take a vaccine that has never been tested on children and mandate it. And so subsequent to this, Pfizer did petition the government to expand the types of people that they're including in their trial to include some people who are sick, because that's been a criticism that there aren't enough real population. Like, who's going to get this vaccine when it hits the general public? It's not going to be perfect patients who have nothing wrong with them. But and they want to include teenagers, but only from age 16 on. And so again, I'll let you decide what you think about it, but I think the disconnect between the trials and what some states are saying they're going to do is very, very concerning. I'll just leave it at that. And I'll finish with this today. The World Health Organization's special envoy on COVID-19 has urged world leaders to stop using lockdowns as the primary control method against the spread of COVID-19. We in the World Health Organization do not advocate lockdowns as the primary means of control of this virus, David Nabarro told The Spectator in an interview aired on October 8th. The only time we believe a lockdown is justified is to buy you time to reorganize, regroup, rebalance your resources, protect your health workers who are exhausted, but by and large, we'd rather not do it. Nabarro pointed to the collateral damage that lockdowns are having worldwide, especially among poorer populations. Just look at what's happened to the tourism industry, for example, in Caribbean or in the Pacific, because people aren't taking their holidays. Look at what's happened to smallholder farmers all over the world because their markets got dented. Look what's happening to poverty levels. It seems we may well have a doubling of world poverty by next year. Seems that we may well have at least a doubling of child malnutrition because children are not getting meals at school and their parents in poor families aren't able to afford it, Nabarro said. This is a terrible, ghastly global catastrophe, actually, and so we really do appeal to all world leaders. Stop using lockdown as your primary control method, develop better systems for doing it, work together and learn from each other, but remember, lockdowns have just one consequence that you must never, ever belittle, and that is making poor people an awful lot poorer. And so I think that that's very telling, that the World Health Organization has basically said that our response to this is excessive, and I've been saying that for a while now, and other people are starting to join in, and this maybe some of these types of people speaking out will go some distance in convincing some people who are for all of this that we really need to change our mind about it. Not a good idea at all. So that's it for now. As usual, pass this on to anybody who you think would benefit from watching it and learning more about all of these issues, and I'll be back to you tomorrow with more news.